Hello and welcome to tonight's webinar. It's a recruitment webinar with Médecins, Frontières Australia. My name is Margaret Bell and I am a midwife and a field worker. I've done 5 placements with MSF in countries like Sudan, Haiti, Nigeria and most recently in Nepal. Currently, I am the manager of the medical unit, which is based here in Sydney, and our focus is on women and child's health, which is the focus of tonight's webinar. So I'm very lucky to have two wonderful expertise sitting beside me. Now we have Marco here. Marco Ola is a paediatrician, and Marco, you've done 5 field placements with MSF as well, and those field placements have been in Mali, Sudan, Angola, Afghanistan and the Central African Republic. Marco is also currently part of the medical unit team here in Sydney, and he is our paediatric implementer. So welcome, Marco.
Thanks, Mark. It's good to be here.
I would also like to say that Marco is actually based in Europe, and he's been in Sydney for the first time for 2 weeks now. So
thank you.
Welcome to Sydney. And then over to my far left is Alan Hughes, and Alan is an obstetrician gynecologist who has had, I think, around 25 years experience in that specialty. Yeah. Alan has done 7 field placements with MSF, and Alan, you have been to the Democratic Republic of the Congo, DRC, Nigeria, Pakistan and South Sudan.
That's correct.
Yes, welcome as well.
And thank you, Margaret, and welcome to everybody watching.
So tonight we have about 30 minutes, and as I mentioned before, our focus is on women and child's health in MSF context. Now, this webinar is not so much about active recruitment, because you can go to the website to find out about the essential criteria for working with us in the field. But what we would like to do tonight is to focus on giving you information about some of our women and child's health programs, our interventions with MSF in our contexts, and also to share with you some of the challenges from the field and the realities of working in the field for obstetricians, paediatricians and midwives predominantly. So I think just to get started, we might start with you, Alan. Oh, actually, sorry, just before that, I'd just like to mention that we do have some questions that have already been posted online, and we won't answer those now because we might find that some of those, the answers to your questions will come up through as we discuss the field context tonight. But please keep posting them, and we will try and answer as many as we can this evening, and if we can't, we certainly will get to you in the next day or two. And excuse me if I do look up, I will just be looking up at your questions above the camera, which is on the screen over there, so that's what I'll be up to. So, as I said, back to you, Alan. Sorry about that. So, we might start with you. So, can you just tell us, in the MSF context, in where we work, why do we need to provide care for women?
Thanks, Mark. Well, some time ago, the UN found that there were 500,000 maternal deaths every year, and that these deaths were largely preventable and overwhelmingly occurred in developing countries. Now, because the maternal mortality, over half of it occurs in 6 countries, MSF saw an opportunity here to intervene and improve things. The maternal mortality, the 5 major causes in developing countries are maternal hemorrhage, hypertensive disease, sepsis, obstructed labor, and unsafe abortions. But then on top of this, there is general poor health, such as anemia, malnutrition, malaria, other HIV and other infectious and parasitic diseases, cardiac disease, renal disease, and all of these contribute to make the situation much more serious. Now then, if you add instability and an area of conflict, then you find a lot of sexual violence, of serious rape, of destruction of medical facilities, sometimes targeting of medical facilities, an interruption to the supply of medicines and medical equipment. A lot of the health professionals will flee to safety, naturally. And the facilities that do remain are often very difficult to access. You also have then shifting populations in large refugee areas and a generally fragile health system, which is made worse by poverty and corruption. If on top of all this, there is a natural disaster such as a volcanic eruption or floods, then you have a truly catastrophic situation.
And I think sometimes in those natural disasters, we often focus on the trauma of the disaster, and often we forget to focus on the women, because women will be having babies, anywhere, aren't they? That doesn't stop in any natural disaster. I think it's also a good point just to point out that the causes of maternal mortality are the same globally, but when you add all the other issues that you mentioned, like the access to care, etc., it just compounds the situation in our context, doesn't it?
Exactly.
Yeah. So, as an obstetrician, what skills can you bring to the field, to our projects? Why is there a need for obstetricians in the field?
Right. Well, in MSF, we all contribute as a team, but specific skills that obstetricians might have, perhaps the ability to help educate our colleagues overseas, perhaps assist midwives and doctors who run into difficult clinical situations there, and be available for any operative intervention that's required. Provide continuity, particularly with maintaining the MSF protocols. It's very, very important not to change protocols every 2 months with a new specialist, and sometimes to help introduce new protocols that have been centrally approved. The most important thing, I think, is to empathize. The doctors and nurses overseas, the national doctors, work extremely hard, extremely long hours. If we can do anything at all to help them out, to relieve their exhaustion, this will translate into better patient care.
And I think the training, as you say, is really important, isn't it? Because often a lot of our national staff don't have access to training, in their countries, so that is a big part of our
so
role.
enthusiastic.
Yeah, they are, aren't they? I know, it's wonderful. You do a training session and they just want more and more. It's very exciting. So Marco, that's a really good sort of overview of, I think, women's health. So for you, I guess as a paediatrician, what do you see as some of the main issues regarding children, in the big picture, I suppose, in the MSF context?
Yes, as you know, children are the most vulnerable ones in our context. I think that Alan has already explained a bit what does it mean work with MSF, especially in our context. Children, they usually are exposed to a lot of disease for lack of hygiene, for lack of clean water, for lack of health facility. The main causes of the main pathologies that we see in the field are especially preventable disease, as pneumonia, meningitis, diarrhea, and malaria. They are still responsible for the high mortality that we see in the developing country, especially in Africa, where we run the majority of our program. Alan talked about also the access to care. The poor access to care is a big challenge for us. Not just for us, that we try to reach the population in distress, but also for the mother, for the children that they are sick. They struggle a lot to reach the hospital. Sometimes it's too late for them. For this reason, the last year we have seen increasing a number of seriously ill patients and admitted in our hospital. This is another big challenge that we are facing today. Is a challenge because in our context sometimes you can't find any you can find qualified human resource, or you have a lot of logistical constraints. Especially in Africa, sometimes you are alone with your stethoscope. You have just to trust on your clinical judgment to provide the best care for the child.
So limited resources for the people and limited resources for you as well.
Exactly.
In relation to diagnostic equipment, etc.
Exactly.
And I think it's interesting you mentioned that, there's lack of hygiene, lack of food, etc., which would be the same for adults. But I imagine the sick child, when you say the seriously sick child, that those children have a multiple problems. And that's kind of what makes them more vulnerable, yeah?
Yes,
Would that be so?
exactly, yes.
Yeah. And malnutrition, is there an
Malnutrition,
issue around
of course, is another part of a lot of patients that they are sick. They are also malnourished for lack of food, but not always. It's still linked to the context.
To the context, yeah. So I guess, so as a doctor, pediatrician, why do you see a need to have pediatricians in the field? Why can't we just have general doctors?
Why? Because the child is not just a little patient or a little adult, and you need someone specialized in pediatric care, especially because in our hospital, in our emergency room or ICU, we have critical patients and sometimes also neonates that they need specific skills and expertise. We currently we run more or less 20 pediatric projects. And you can imagine that the needs that we are in terms of human resource, in terms of pediatrician, neonatologists, but also in terms of nurses, pediatric nurses and neonatal nurses. Not just to manage the case inside the hospital or in the clinics, but also, as we have already said, to support our staff in the field, to train them and to exchange ideas, to bring new ideas and new intervention in the developing country.
And can you mentioned neonatal care, so can you just maybe describe to us some of the interventions we have for neonates, for sick neonates?
Yes. Today is our priority. Neonatal care is one of our priority. We run more or less 14 neonatal units in collaboration with the maternity, with midwife or obstetrician. We provide the majority of this project are in Africa, but you can find also projects in Afghanistan, Pakistan, or Jordan. In Africa, we provide basic neonatal care. It means that we are focused especially on the antenatal care, routine care, the birth, management of sepsis, management of lower weight. We are trying to implement, especially in Africa, where we can't use incubator, the kangaroo mother care, the skin-to-skin contact that is a simple intervention with a high impact on the mortality, neonatal mortality rate.
Great. And I think, as a midwife, we're kind of a little bit of we work with both of you in the field. I think, don't we? We sort of, clearly, midwives manage labour and delivery, so we're often working autonomously or with obstetricians in the field. And then, of course, we work very closely with paediatricians, particularly in relation to neonates. As midwives, it could be our responsibility to care for the neonate, the well neonate at birth, or manage the sick neonate for a period of time until we can hand that baby over to a paediatrician or a doctor who can take care of that child. So what I might do now, you have introduced the interventions, talking about neonatal care. So I might just move to some women's health interventions now, just to try and give you an idea as to what our interventions are in the field. So they do vary. So we might have a standalone women's health program, or we might be providing women's health in another IPD situation, in a general hospital. We might be working with the Ministry of Health, working in their maternity. So we have quite a variety, and of course this can be in stable or conflict situations or natural disasters. So one of the types of care we provide is what we call basic emergency obstetric care, and you may hear that referred to as a BMONC. Some of you are probably familiar with that term. And I guess as a midwife, that is often places where we would work. And as some of you may know, a BMONC provides safe delivery care, vaginal delivery care. We provide care for the neonate, basic resuscitation, and then of course we refer for the complicated cases. So we can't manage, any major complications or things that might require surgical intervention in a BMONC. Part of the BMONC as well is we might set up antenatal care, postnatal care, particularly family planning, because I think as we mentioned the high rates of maternal mortality, but of course one of the ways to help prevent maternal mortality is to provide family planning, which is often non-existent in these contexts. And of course then I think also we try to prevent the complications from unsafe abortion. So we'll provide safe abortion care if we are able to, or we will refer or certainly help the woman get to a facility where she can access that care. So I think as a midwife, and for all those midwives out there, it's quite a broad range, but our focus, you need to have the confidence and the experience in working in labour, complicated pregnancies and delivery, because that is primarily where we do centre our focus initially to start. And it can be a little bit scary, I think, we can work autonomously, as I mentioned, or we can be in facilities, working with obstetricians. But, it can be a little bit scary in the beginning when you're working by yourself. But it can be also really rewarding as well, because you do get to work with some amazing national staff. Now, I might just hand over to you, Alan, just to describe the more comprehensive care that we provide in our women's health interventions.
Thanks, Mark. In contradistinction to BMONC, which is the basic care, there are also CMONC facilities, which C for comprehensive. And this is where obstetricians are more likely to be involved. We liaise very closely with the basic care facilities, providing advice and, if necessary, see patients that require transfer. The UN suggested that there should be a comprehensive facility for every 500,000 patients. As a rule of thumb.
Which doesn't always happen, does it?
No, we might be lucky.
Yeah, exactly.
So, for instance, if Marg might be working in Hanggu in Pakistan in a BMONC facility, and there was a patient that required operative intervention, for instance, she might contact me in Peshawar in a CMONC facility and arrange transfer.
And I think that's a great example, actually. It's probably one of the few examples where, as MSF, we are doing the BMONC care, and then we're also doing the CMONC care. And actually, in both places, we're doing neonatal care. We've got neonatal units. So that's a really good example.
Seamless transition in theory.
Exactly.
Anyway.
Yeah, exactly.
Yeah.
Which often doesn't happen. Often, isn't it? We will have MSF might be setting up the BMONC and managing the BMONC with some neonatal care. Then we might be referring to a Ministry of Health hospital in the country we work for the more advanced care, or vice versa. So it really depends on the context, doesn't it, as to what we do. Marco, now you have mentioned the neonatal intervention, but if you can just maybe give us a general perspective on what are some of the paediatric interventions, because I'm sure they're quite broad as well.
Yes, of course. We have basically two lines of intervention. One is prevent the disease, and for this reason we are focused on the vaccination campaign. As we are doing now in Central African Republic, we are trying to vaccinate more or less all the children present in Central Africa, because they have a big problem with the measles, but also with the meningitis, with the pneumonia. So as pediatrician, you can work, you can be involved in this campaign. But also you can also be involved in the outpatient strategy. You can work inside the refugee camp in the clinics to provide primary care. You can be also in charge for the HIV or tuberculosis program, because we have a different program. We have a lot of children with HIV and tuberculosis that need to be followed. We need pediatrician also for this, but in general, because we don't have a lot of pediatricians, we are looking for them. We are trying to keep them inside the hospital where we have the critical patient or the critical neonates. where they can work with critical patient inside the emergency room, inside the intensive care, and inside the NICU. We need specialized doctors.
Yeah.
Usually, we try to set our intervention according to the context. It means to set our level of care. Especially in Africa, we provide basic pediatric care or basic neonatal care because we have a lot of constraint with the logistic. An example, no power, no electricity, and especially we don't have enough human resource that they are qualified.
So when you say basic care, what do you mean exactly?
Basic care, it means, I can give you an example in South Sudan.
Yes.
Where we can summarize all these problem. We have an emergency room.
Yeah.
We have an intensive care. Our best tools is the pediatrician.
Yeah.
That is just with his stethoscope. But we don't have any monitors. You can provide CPAP. Or we can provide any invasive intervention for a lot of constraints that are linked to the context.
You could manage infection, for example.
We can manage the infection. We can manage all the disease.
Yes.
We have a high impact on this. Also, if we provide basic care, our mortality in the hospital is normal. Is normal, but of course, if you have monitors, if you have more tools, we can improve, we can increase our level of care.
So
But
normal
you
for
need more
that
staff.
context, but probably still a bit higher than obviously general context.
Exactly.
But I think that probably also goes to show that you don't need often high technological interventions to have an impact.
To have a good
Would
results.
you agree? Yeah. And I think KMC is part of that, Kangaroo Mother Care, for those who might not have heard of that.
Kangaroo.
In the absence of an incubator.
Exactly, is an example of simple intervention, cheap, simple intervention that has an high impact on the neonatal mortality rate. We start at the birth with the skin-to-skin contact. We can avoid the hypothermia, we can stimulate the breastfeeding.
Yeah.
We decrease also the risk of sepsis, infection, and we are also promoting especially the breastfeeding that could be sometimes a problem.
Yeah.
But this is a typical, we don't have any incubators, but we can implement other interventions as the Kangaroo Mother Care to have good results.
Have an impact.
Good results.
Yeah, which is great. And I guess even with obstetrics, with women's health, that sometimes just small interventions can have a big impact.
Exactly.
Yeah, like having a good birth attendant to manage PPH or things like that. Yeah.
Often small interventions are the most effective.
Yeah. And something I actually failed to mention in relation to women's health is sexual violence, because we're probably all quite aware that it is a very big problem, and in a lot of the contexts where MSF works, and we do know that in conflict situations or in natural disasters, when populations are displaced, their rate of sexual violence can increase. And as a medical organisation, we are focused on providing medical care, which of course can include, prevention of STIs, prevention of HIV, transmission, prevention of pregnancy or management of unplanned pregnancy, unwanted pregnancy, hepatitis B, tetanus vaccination. And then, of course, a large component of that is psychological care and mental health care. So that is something we either do what we call in the vertical programs. You might be familiar with that kind of, what's the word I'm looking for, that kind of term, where we have a standalone sexual violence program, or it might be included in our general health program. And Alan, I think you told me a story earlier about the Congo you'd been involved with.
Yes.
Sexual violence.
Recently, I've just returned from the Congo. I was over there for 3 months helping mentor some of the national doctors. While I was there, I was looking through some statistics that were 2 years old when the rebels held that territory. and there was a situation of conflict. There were, as expected, perhaps 100 blessures or wounds caused by gunshot or machete that our surgical colleagues were flat out dealing with. But then I noted a column called viol, which was about half as much, 40 to 50. And I thought, this is a strange term. My French is not very good. And I thought perhaps this applied to some violent episodes, but it was strange that it was so non-specific to being as statistical. And then it finally hit me that they were talking about episodes of severe sexual violence, severe enough to need medical treatment, which was really the tip of the iceberg for all the rapes and violence that actually occurred. So I looked around, and what had MSF done with this? Really, it was epidemic proportions. And they'd actually gone out and found and trained national psychologists who understood the context and who spoke Swahili, who spoke the native language, to assist the ladies. And I thought, wow, imagine trauma psychologists in the middle of nowhere. I mean, anything's possible.
Exactly, and I think that's probably something that we often forget, or probably we don't think about before we go to the field. That, and you know, we try to have the least amount of expats or international staff in the field as possible, and the most of our national staff, you know, and they can be extremely skilled often, certainly very knowledgeable, because they know the context and know the people and who to talk to, who not to talk to, and and as we've mentioned before, you know, our big part of our job is to train, support, educate. And it might be a good opportunity to mention that another part of our role is also to manage people, and often we don't have a lot of experience. I'm not sure about paediatricians or obstetricians. Certainly midwives, perhaps in our nursing careers on the wards, we do some management experience. But we're in the field, we might be managing, you know, that national staff team, and that can sometimes be a challenge for us.
Absolutely.
I might just mention, you did mention earlier, Alan, about the protocols, and I think it's quite relevant because I think, Marco, you know, talking about the paediatrics, there seems to be such a broad range of interventions, and you almost feel like you need to be an expert in everything. But I think it might be really good just to let you know that we do have guidelines and protocols. I don't know if you can see this book, it's probably a little bit pale on the screen, but this is our the latest version of our essential obstetric and neonatal care, and this has been revised just recently by Women's Health Advisors. Can you see that there? And I think, so this is really important. So when you are in the field, we don't expect you to invent anything. These guidelines and protocols are there, and we've written them to be context specific, because, you know, obviously what is going to apply here, say in Royal Prince Alfred in Sydney, to treat preeclampsia or to treat neonatal sepsis might be different in South Sudan, you know, because of the context you're in, what you have access to, drugs that are available, et cetera, et cetera. So, you know, we do say to people that you don't have to know everything. The protocols are there. You can refer to them. You've never treated malaria before. It's very clear about the drug regimes that you need to give. So just to help people with that. So I might just Marco, I might just go to you now. So I guess if for the potential paediatricians out there who are thinking of going to the field, what could be something that you could advise them, experience to get or to gain before they go, or things that they might do in preparation to go to the field with MSF?
Yes, I think that one of the most important things is to get as much information as possible. It's better to talk with someone that has experience and background with MSF. This the way binary. It is a good opportunity to get this information. You need to ask yourself if this is really what you want to do, especially if you are ready. Ready also in the professional point of view. Of course, the big part of our job is inside to the hospital, inside the emergency room, the ICU, and the NICU. It's good to have experience in in this field. If not, you can improve your skill. You can do some courses as the pediatric advanced life support or the neonatal resuscitation course. But always another things that we have to take in account, that you have to try to be prepared on what you are going to face, because Alan was talking about the violence, about the rape, all these bad things that we can we can see, especially in the conflict area.
Yes.
When you arrive in the field, you have to remember to be diplomatic with our colleagues, be collaborative, especially you have to keep smiling with the patient, with the staff.
Even if you feel like crying, you've got to keep smiling.
Another things that try to understand the context, because sometimes the context could be shocking. And listen your colleagues and work with them, because they have experience and they know how to manage difficult problem. Exactly.
So it's very much teamwork, I think, isn't it, Alan? Would you agree?
Yeah, absolutely. I think overall mindset's probably the most important thing, is preparation. As a specialist, you're well trained and competent, but you'll be part of a team working with very little technology, with no lab work, and you'll see conditions that you've probably never seen before. Some of these will be quite commonplace for the midwives and doctors that you're working with. So you have to be receptive to advice, I think, as Marcos said. Also, their practice can be defined by a different set of cultural taboos. So I guess in a nutshell, my advice might be to be quietly confident in your own ability, but to be suitably humble. So sit back, observe how things go for a few days, be non-judgmental. Perhaps learn how to greet your colleagues and patients in their own language, I think is good. And above all, there's a magnificent opportunity to grow medically, to grow culturally, but especially to grow personally. And along the way, you get the satisfaction of having contributed, and you might even save a life or two, which is a good thing. Which is a good thing. It is a good thing. It said to save one life is to save all of humanity.
And I think when you work in the team, I think it's remembering, isn't it, that you don't have to. Well, of course, you have to save that life, but you are not personally responsible for that. The team work together, and you all manage that together. So I think that's really important, and I can really relate to, I think, the comment you just then made about you'll see things that you'll never see before. Because I remember my first mission, I was given that information by the person who recruited me, and by another midwife I spoke to before I went to the field, and it is true. And I think part of the reason is that thank goodness, but our healthcare here, say in countries like Australia or Italy, is very good. So we never see the complicated maternal cases or pediatric cases, because we have so much better healthcare here, or access to care as well. So you don't see it. So for me, like as midwives, I would say the best experience you could get would be to try and do some remote area nursing. And we are so lucky that in Australia we have access to a lot of remote areas. Obviously Europe, it's a bit more difficult. But I certainly did. I had some experience in Indigenous communities before I went, and it was really good foundation in the sense of the isolation, working in a different culture, working with limited resources, and I guess just thinking outside the square and, trying to think of all those things that you've learnt over the years. So I would think for midwives that it was certainly something you could certainly do as well. And And I guess just the other thing in relation to midwifery, I think it's because you could be working alone, autonomously, with your national staff, but without, say, an obstetrician for support in that particular project. So you do need to get some recent experience, clinical experience in delivery, complicated labours, complicated pregnancies, and delivery care, because that will just help you, face some of those challenges in the field. And if possible, if you can get some experience in managing a team and training, and that can come in all forms, but that is also an advantage. And I'm not sure how you two have found, but I know in the field often we feel we need to reinvent training materials and all that sort of thing, but we do have a lot of those things already available, so it's always good to contact your coordination team or your advisors to get that.
Yes, just to say that you are not alone in the field. Usually you work with someone that has already experience, and you are always you can get the support of the medical department or the support that came from the advisor, in this case from the pediatric advisor.
Yes.
MSF's very good that way at giving advice over distance.
Exactly.
All right, so we might go to some questions. Now, let's see. So Bettina's asking, thank you for taking the time to speak tonight. That's our pleasure. My question is regarding coming back to work in Australia following a mission. Was it difficult to settle back in? And if so, how do you cope? Okay, who would like to answer that? Alan?
I could perhaps start. Yes, it can certainly be difficult to settle back in two contexts, I think. The situation can be a bit schizophrenic when you come back, because you've seen things that you've never imagined before overseas, so that when people perhaps complain about the price of petrol or something here, you're not immediately very sympathetic. And that can distance you a bit from people that you were close to before. Additionally, it's always, I think universally for us, it's amazing how little interest there is from most people in working overseas. For us, it's so important. And a lot of people don't see beyond, their city or their state or certainly their country.
Which actually brings me, I guess, to another thought, that there is a possibility of actually a career with MSF. And I know, Alan, you've done your career with MSF has been doing field placements.
Yes.
And how do you fit that in with your work, your everyday work back here in Australia?
Yeah, 7 years ago I took early retirement, and I'd highly recommend this for people that are a little bit before retirement age, but looking for time to be involved in the first mission. It gives you time for locum work, for holidays, for spare time, and also for working overseas, for instance, with MSF. So this is a possibility now. Yeah.
And are there any other strategies that you'd like to manage that work?
The difficulty is that MSF actually quite rightly demands a bit of experience post-fellowship from specialists before sending them to act alone overseas, and that's quite right. But the problem is that people are actually by that time involved, working full-time, on the treadmill, and often with social obligations as well. But things are a bit more flexible now, so there is a possibility of group practice. For instance, getting 3 specialists to work 8 months a year to fill 2 positions. Or often you can work for 3 years and take 1 year off and get paid for 4 years. And all these things are worth looking at for that very important first mission before you decide to plunge in.
And your career, Marco, you sort of went in a different direction. So you started as a pediatrician in the field.
It's a bit different because I started when I was still a resident. And I did a couple of missions then with MSF. If you can survive to the mission.
Eating potatoes and peas every night.
Exactly, no, because sometimes it's difficult to come back, but after it became easy to come back and then to live on another time. But at the end, I decided to work permanently with MSF. It is for this reason that I'm in this position now as a pediatric implementer. But we are full of opportunity. You can work in the operations and
Which
be
is
more
in
involved.
the headquarters, like the big, you mean in Paris, the big offices and headquarters, yeah.
After a couple of years, of course, a
Yeah.
lot of
A couple of years
experience.
experience.
Just to try to work with the strategies.
Yes.
Or in the medical department as a specialist, as pediatric advisor or as advisor in vaccination. But also you can work as a researcher.
Researcher, yes.
Researcher.
Yes.
Because today we are trying to to implement a lot of studies because we have gap in this in this field. It could be a good opportunity work with MSF. You can choose different how do you say, Pat?
Yes. Which I think is really good to know, because often before you do your first mission you think it's the only option is for the field work, but you can move into a different place. And I guess for myself as a midwife, I did start in the field, and after my full field placements then I sort of did a few field placements, had a few years off, went back into the hospital. I was very lucky. The hospital I worked in gave me leave without pay each time for my 6-month missions. And then this job came up 2 years ago and I applied for it and was very lucky to get it. So I am with full-time with MSF now. I just want to just quickly go back to the question, the previous question. I'm sorry, I can't remember the name who posted that question, but how do you cope when you return? Just one point on that is that MSF does provide psychological support for you when you get back. And it's not compulsory, but it is available and it is confidential. And I am very happy to say that I have accessed that myself, particularly after one of my very difficult missions, my second one, which was in Darfur in the middle of the conflict. I found it quite traumatic when I came home. And I found that just fantastic. It just helped put it all into perspective for me and helped me fit back into reality here when you've come from such a shocking reality there. So MSF does really, encourage that as well. And writing letters home was my great thing. My diary every night.
Yes.
Now we might just go to another question. Catherine's question is, what is the best day you've ever had with MSF and why was it so good? Well, I've got one that I always remember, but I won't take over if the boys have one they'd like to talk about.
Well, I think for obstetricians, it's often a lady, a mother that survives against all the odds, and there are one or two of those happily, and it's for great rejoicing when that happens. Yeah.
It's quite just seeing the the resilience in the human spirit is quite amazing. I just want to tell you my story because it is so it's quite emotional when I think about it, but we had this woman and she came to an antenatal clinic this is my first mission in South Sudan, and she was in late 20s and she'd had 5 previous pregnancies, all had ended in stillbirth babies, delivered by her husband, in her words, and she was pregnant again, and she came to us just to be sure that if she came back to have the baby, we could make sure that her baby was born alive. Because this was back in the days when we didn't have an operating theatre, and which possibly was what she needed, having already delivered 5 stillborn babies. So there was a hospital in the north of Kenya, an ICRC Red Cross hospital, and we were able to transfer her there for an elective caesarean section, which was very great because they were only taking emergencies back in those days. And so my best day was when she came back on the plane, because she could only access the mission by plane, and she got off the plane and she had this beautiful baby in her arms. And, it's, I guess those days just totally make the bad days they outweigh the bad days, I suppose. So it's kind of an up and down, isn't it? It's really kind of the highs and the lows. You kind of go on a bit of a
roller coaster.
That's the one. Marco, just before we finish, you've got any story you'd like to share? Or
Yes, no, the specific history. I think that one of them, my best day is usually when at the end of the month when you used to do the statistics.
Oh, we all hate doing statistics. Yes, you've got to do them in MSF.
Why? Because at the end you are always working. Then at the end of the month you see your result. You see that you have treated I don't know how many patients,
Yeah.
600, 800,
Yeah.
900, and then you see that you have treated, you have saved
Yeah.
a lot of
Yeah.
of lives.
Yeah.
You,
So doing statistics can be a really good thing.
yes, it's a good thing.
Look,
Do
I
research.
think I think we're running out of time, and there are many questions. So thank you so much for all of them. It's been wonderful to know there's so many people out there listening to us and watching us, I suppose. And we will get to answer all of those questions in the next couple of days. So please be patient. We will get to you eventually. So I think, I think that's probably all we have time for. So I'd just like to thank Alan and Marco,
Thank you.
especially coming all the way from Italy to be with us here in Australia. And to thank you very much for attending tonight. It's been really, we've loved being here to share our experiences with you. And we hope that you will keep looking at our website and you will come back for another webinar at some point. I'm not sure when the next one is, but I'm sure that will be posted on the website. So thank you once again and have a good evening. Thank you. Good night.
Thank you.
Thank you.
Thank you.